I want to talk to you today about a family of medications that a great many of you will be taking, and that has one particular property that makes understanding it genuinely important. Beta blockers, bisoprolol, metoprolol, atenolol, carvedilol, propranolol, nebivolol, and their relatives. If you've had a heart attack, if you have heart failure, if you have atrial fibrillation, angina, or high blood pressure, there's a good chance one of these is part of your daily routine. And here's the property I mentioned. And the reason this video exists, beta blockers are the medication class where stopping suddenly is genuinely dangerous. Not merely unwise, not merely a return to how you were before, but actively hazardous, because your body adapts to them in a way that means abrupt withdrawal can trigger a dangerous rebound. And yet, these are also tablets that people quietly stop because they can make you feel tired or cold or flat, and because it's tempting to think that a medication which makes you feel worse can't be doing much good. So, today, calmly and in balance, I want to give you the understanding that lets you take this medication safely, and just as importantly, the understanding that lets you have a proper conversation with your doctor if it isn't suiting you. So today I'll explain what beta blockers actually do and why they're prescribed, why they make you feel the way they do, so their side effects stop being mysterious, the specific issues that matter after 70, including the fall risk and the effect on your pulse, the crucial interactions, and the diabetes point that could genuinely matter for your safety, the golden rule about never stopping suddenly, and the symptoms that mean call your doctor. And as always on this channel, nothing here is a reason to change what you take, only a reason to have a better conversation about it. Let me begin with the mechanism. Let me explain what a beta blocker actually does, because once you understand it, every side effect on the list stops being random. Your body has a fight or flight system driven by adrenaline and noradrenaline, and those hormones act on receptors called beta receptors. Beta 1 receptors sit mainly in the heart, and when adrenaline hits them, the heart beats faster and harder. Beta 2 receptors sit in the lungs, the blood vessels, and elsewhere, and are involved in opening the airways and other functions. A beta blocker occupies those receptors and blocks adrenaline from reaching them, so the effect is a heart that beats more slowly and with less force. Now think about what that achieves. A slower, gentler heartbeat uses less oxygen, which is exactly what you want in angina, where the problem is a heart muscle not getting enough blood. It reduces the workload on a damaged or failing heart, which is why beta blockers improve survival after a heart attack, and in heart failure, this is one of the best established benefits in all of cardiology. It slows and controls the rate in atrial fibrillation, it reduces blood pressure, and it reduces the tremor and racing heart of anxiety and of an overactive thyroid, which is why propranolol is used for those too. So the tablet blocks adrenaline at the heart, producing a slower, calmer, less demanding heartbeat. And that single action explains the benefit in heart attack recovery, heart failure, angina, atrial fibrillation, and blood pressure. And it also explains, as you'll see, almost every side effect. Now, the important distinction between types. Let me give you a distinction that matters practically. Some beta blockers are cardioselective, meaning they act mainly on the beta 1 receptors in the heart and much less on the beta 2 receptors elsewhere. And these include bisoprolol, metoprolol, atenolol, and nebivolol. Others are non-selective, blocking both types, and these include propranolol and carvedilol. Why does this matter to you? Chiefly because of the lungs. Blocking beta 2 receptors in the airways can cause them to narrow, which is a genuine problem for people with asthma and can be a consideration in COPD, so the cardio-selective ones are generally preferred and are frequently used safely even in people with lung disease under medical supervision, whereas non-selective ones need more caution. It also matters somewhat for cold hands and feet and for the diabetes issue I'll come to. So, if you have any lung condition, it's worth knowing which type you're on and making sure your doctor knows about your chest as well as your heart. And a second distinction worth knowing: in heart failure specifically, only certain beta blockers have been proven to improve survival, principally bisoprolol, carvedilol, and a particular long-acting form of metoprolol, and they must be started at very low doses and increase slowly, because starting too fast in heart failure can temporarily worsen it. That's why if you have heart failure and your doctor is creeping your dose up over months, that is deliberate and correct, not indecision. So cardioselective versus non-selective matters for your lungs, and in heart failure, the specific drug and the slow upward titration are both deliberate. Now let me explain how these tablets make you feel. Let me talk about the side effects, and I want to frame them properly because they follow logically from the mechanism, and that makes them easier to judge. If you have blocked your body's ability to raise your heart rate and force, then when you need extra output, climbing stairs, hurrying, feeling emotional, your heart can't respond as it used to. So, the most common complaint is fatigue, a feeling of being flat, tired, or that you have less in the tank, and reduced exercise capacity, feeling puffed sooner than you expect. This is real. It's the commonest reason people quietly stop taking them. And it's worth knowing that it often improves over the first few weeks as you adjust, so giving it time is reasonable. But if it persists and is genuinely limiting your life, that is a legitimate conversation because sometimes a different beta blocker, a lower dose, or a different strategy suits you better. Second, cold hands and feet because reduced cardiac output and some vessel effects mean less blood to the extremities, and this is extremely common and connects to my video about always feeling cold. Third, a slow pulse, which is the intended effect but can go too far, and I'll come to the numbers. Fourth, dizziness and lightheadedness, particularly on standing, because the tablet blunts the reflex that normally speeds your heart when you stand up, and this is where the fall risk lives, which deserves its own section. Fifth, sleep disturbance and vivid dreams or nightmares, which are more associated with the ones that cross into the brain more readily, like propranolol, and are worth mentioning because they're distressing and often solvable by switching. Sixth, low mood, which has been debated for decades, and the fairest summary is that it's less common than folklore suggests, but does occur in some people, and is worth reporting rather than enduring. Seventh, breathlessness or wheeze if you have airway disease. And eighth, sexual side effects, which are underreported because people are embarrassed and which are a perfectly legitimate reason to ask about alternatives. So the side effects are the mechanism showing itself: less reserve, colder extremities, a slower pulse, dizziness on standing, and sometimes sleep and mood effects. And every one of them is a conversation rather than a reason to stop. Let me talk about falls and your pulse because these are the two things that matter most after 70. First, falls. Beta blockers contribute to falls through two routes: the dizziness on standing that I described, because your heart can't accelerate to compensate for the drop in blood pressure when you rise, and general fatigue and slowed reactions. And this risk is multiplied when they're combined with other blood pressure medications, diuretics, or sedatives, which is extremely common. So the practical protections are the ones I give across this channel: rise in stages, sitting on the edge of the bed before standing and pausing before walking, especially in the morning and at night. Keep your home well lit and clear, stay hydrated, and report persistent dizziness rather than adapting around it, because dose adjustments and timing changes often fix it. Second, your pulse. Since the whole point of the tablet is to slow your heart, you should know what your pulse is running at, and I'd encourage anyone on a beta blocker to learn the pulse check I've taught before. 2 fingers on the wrist, count for 30 seconds, and double it. Broadly speaking, a resting pulse in the 50s is often expected and perfectly acceptable on this medication if you feel well. What deserves attention is a resting pulse below about 50, particularly if it comes with symptoms: dizziness, fainting or near fainting, unusual fatigue, or breathlessness, because that combination suggests the heart is being slowed too much and the dose may need adjusting. So please do not adjust it yourself, but do take that information to your doctor, because a person who can say my resting pulse has been running at 46 and I've been dizzy is giving their doctor something genuinely actionable. And note that if you also take other rate-slowing medications such as digoxin or certain calcium channel blockers like verapamil or diltiazem, the effects add together, which is why those combinations need careful supervision. So know your pulse, expect the 50s, report the 40s with symptoms, and rise in stages to protect against falls. Let me give you the interactions and special situations that genuinely matter, and one of them could affect your safety in a way you'd never guess. First, and most importantly, diabetes. If you take insulin or certain diabetes medications that can cause low blood sugar, this matters a great deal. When your blood sugar drops dangerously low, your body's warning system is largely adrenaline. That's what produces the classic early symptoms: the shaking, the pounding heart, the anxiety that tell you to eat something now. A beta blocker blocks precisely those warning signs, which means hypoglycemia can become masked, and you may not notice it until you're much further along, confused, or sweating, since sweating is one warning that generally does persist. Now, this does not mean people with diabetes can't take beta blockers. They very often should, particularly after a heart attack where the benefit is large, but it does mean you should be aware of it, Monitor your blood sugar more carefully, know that sweating may be your remaining warning, and make sure your diabetes team knows you're on one. Second, lung disease, as I explained. Tell your doctor about any asthma or COPD and report any new wheeze or breathlessness. Third, other rate-slowing drugs, which I've mentioned. Fourth, do not combine with certain decongestants and stimulant cold remedies without checking, since they work against the medication. Fifth, alcohol, which compounds the dizziness. Sixth, if you have peripheral artery disease, beta blockers were once avoided, and current understanding is that they're generally acceptable, but cold extremities may worsen, so mention it. And seventh, surgery and dental work, where you should always tell the team you're on a beta blocker because in most cases it's specifically continued through surgery. And stopping it around an operation is one of the classic ways the rebound problem I'm about to describe gets triggered. So the diabetes masking point is the big one, along with lungs, drug combinations, and telling every surgical team. And now, the golden rule. Here's the golden rule of this entire class of medication, and I want you to remember it precisely. Never stop a beta blocker suddenly. Here's why, and the reason is mechanically elegant and genuinely important. When you block beta receptors for weeks and months, your body compensates by making more of them. This is called upregulation. So your heart becomes populated with a greater number of receptors, all of them currently blocked. Now imagine abruptly removing the blockade. Suddenly, your own circulating adrenaline has access to a larger than normal army of receptors, and the effect is a rebound, an exaggerated response, and the consequences are well documented: a sharp rise in blood pressure, a racing heart, palpitations, and most seriously, a genuine increase in the risk of angina, heart attack, and dangerous heart rhythms, particularly in people who have underlying coronary disease. This rebound typically appears within days of stopping. So the rule is absolute. If you and your doctor decide to stop a beta blocker, it must be tapered, gradually reduced over 1 to 2 weeks or longer under medical guidance, which leads to the practical implications: do not let yourself run out of tablets, and if you're going away, take more than you need. Do not stop because you feel well, because with these medications you are being protected against something you cannot feel. Do not stop because of side effects. Instead, report them because there are usually alternatives within the same class or a different strategy altogether. Do not stop before surgery unless specifically instructed. And importantly, if you have been unwell and unable to keep tablets down for a day or two, tell your doctor rather than quietly restarting later. So the mechanism is receptor upregulation. The consequence of abrupt stopping is rebound with real cardiac risk, and the answer is always a supervised taper. Let me be very clear about when to contact your doctor. Seek emergency help for chest pain or pressure, especially with breathlessness, sweating, or nausea, for fainting or collapse, for severe breathlessness, and for a very slow pulse with confusion or collapse. Contact your doctor promptly within days for a resting pulse persistently below about 50, particularly with dizziness, fatigue, or near fainting, for repeated dizziness or lightheadedness on standing, or any fall, for new or worsening breathlessness, wheeze, or swollen ankles, which in someone with heart failure can indicate the condition is worsening, for very cold, painful, or discolored hands and feet, for new significant low mood, or for nightmares and sleep disturbance that are affecting you. Contact your doctor non-urgently but genuinely for persistent fatigue that's limiting your life, for sexual side effects, and before any surgery or dental procedure. And for people with diabetes, contact your team if you're finding hypoglycemia harder to detect. And of course, contact them rather than stopping, always, whatever the reason. So, chest pain, fainting, and severe breathlessness are emergencies. A slow pulse with symptoms and repeated dizziness are prompt calls. And fatigue, mood, and sexual side effects are conversations worth having rather than reasons to quietly stop. Let me paint you a picture. Picture a man of 74 who had a heart attack 2 years ago and was started on bisoprolol along with his other medications. Over the following months, he noticed he had less energy for the garden and that his hands were always cold, and he began to wonder whether the tablet was worth it. And one week, while away visiting family, he ran out and simply didn't bother getting more, reasoning that he felt no different when he skipped a day. 4 days later, he developed a pounding, racing heart. His blood pressure rose sharply, and he experienced the chest tightness he hadn't felt since his heart attack, which frightened him into hospital, where the cause was quickly identified as beta blocker withdrawal. Now picture the same man with the knowledge in this video who instead brings his concerns to his doctor at a routine appointment and says, "I'm tired and my hands are always cold. Is there anything we can do?" And whose doctor reviews his dose, considers a different beta blocker, checks his thyroid and iron because being cold and tired has other causes too, and arrives at an arrangement he can live with while the protection continues uninterrupted. Same man, same complaints, and the difference between a hospital admission and a solved problem was one conversation instead of one silent decision. That's really the whole message. And let me speak briefly to those caring for an older parent or partner. Know that this is a medication where running out genuinely matters, so help keep the prescription ahead of schedule and make sure a spare supply travels with them on holidays and hospital stays. Teach and encourage the pulse check because a slow pulse with dizziness is something you can detect at home and hand to a doctor as useful information. Watch for the fall risk, particularly in the first weeks and after any dose change, and support staged rising and a well lit home. Listen for the quiet complaints, the tiredness, the flatness, the coldness, the nightmares, because these are exactly what causes people to abandon a life saving tablet in silence, and they are all things a doctor can work with. And if they have diabetes, understand the masked hypoglycemia point and watch for confusion or sweating without the usual shakiness. And make sure every clinician, especially any surgeon or dentist, knows they take a beta blocker. So let me draw this all together calmly. Beta blockers block adrenaline at the heart, producing a slower, gentler heartbeat that uses less oxygen and demands less of a damaged heart, which is why they improve survival after heart attacks and in heart failure, control atrial fibrillation, relieve angina, and lower blood pressure. That same mechanism explains their side effects: the fatigue and reduced reserve, the cold hands and feet, the slow pulse, and the dizziness on standing that, after 70, is the main route to falls. The specific things worth knowing at this age are your pulse, expecting the 50s and reporting the 40s with symptoms, the fall protections of staged rising and a safe home, whether your beta blocker is cardioselective if you have any lung disease, and if you have diabetes, that these tablets mask the early warning signs of low blood sugar. And above everything sits the golden rule: never stop suddenly because your body has grown extra receptors in response to the blockade, and abrupt withdrawal produces a genuine rebound with real cardiac risk. So any ending must be a slow, supervised taper. So here's what I'll leave you with, straight and clear. First, understand that what you feel, the tiredness and the coldness, is the medication working rather than the medication failing, and that it's still worth reporting if it's limiting your life. Second, learn your pulse, check it occasionally, and bring the number to your appointments. Third, protect yourself against falls with staged rising, hydration, and a well-lit home, especially in the first weeks and after any dose change. Fourth, if you have diabetes, know that your early hypoglycemia warnings are muted and monitor accordingly. And if you have lung disease or upcoming surgery, make sure everyone knows what you take. And fifth, above all, never stop suddenly, never run out, and never let a side effect become a silent decision, because these tablets are protecting you from something you cannot feel, and the day you stop feeling their effects is not the day they stopped mattering. A beta blocker is a genuinely life-prolonging medication for many of the people watching this, and it asks in return only that you understand it, monitor it a little, and speak up instead of stopping. So take care of yourself, know your pulse, rise slowly, keep your supply ahead, and take your questions to your doctor rather than to your own conclusions. And because doses, alternatives, and any tapering belong entirely to your prescriber, please treat side effects and any wish to stop as a conversation with your own physician. Treat a slow pulse with dizziness or repeated falls as a prompt call, and treat chest pain, fainting, or severe breathlessness as your reason to seek emergency help immediately.